All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. Today we're going to talk about a hypothesis, an article by David E. Scheim about the ivermectin's role in preventing hypercoagulable state with COVID-19 and the possible dose that may be necessary for it. Again, spilling the beans, he is proposing a higher dose. So stay in this. This is the primary discussion, and we would go over the mechanism that he's proposing. If that is an actual mechanism, that will mean that all the mechanisms that we have read before, this will be one more mechanism in that. And I'll have to do one more updated video as well. So let's start. So this is drbeen.com. This is the paper by David Scheim. And you can actually read the paper here. I have downloaded the PDF and marked it that you can do from here. One of the protein he discusses is the CD147. This is the article about that. This is another article about the CD147 and its use or its role in COVID-19 and the role of azithromycin's efficacy that doctors have been thinking about for a long time, that why is azithromycin an antibacterial helping with the virus here? Just like why is an ivermectin an anti-parasitic helping here, similar here too. And so they have also talked about CD147. Then is the Plasmodium falciparum that is also in the play here. So malaria is something that is also in the play. So we'll talk about that as well. So it is interesting, hydroxychloroquine, chloroquine, malaria, then the one more discussion of ivermectin in the context of malaria as well. So let's see what is going on. This is the article. I'm going to illustrate it and then we can look at some of the highlights in these articles. So here we are. This is my version of Ivermectin Man. I did not know that it has become actually quite popular. I was on a podcast interview this morning with Julian. Julian is actually the one who also suggested me to read this article. And he was also very much talking about the Ivermectin Man. So here we are. Let's look at the theory. First of all, about CD147. CD147 is a protein on many of our cells, but most importantly on red blood cells. Remember, CD means cluster of designation. And just like our hair, I always give the example with hair, just like all of us have different hairstyles and hair colors. We have blondes, we have brunes, we have people without hair, we have people with my gray hair, and so on. And you can sometimes refer to someone and say, remember that guy with the gray hair? Same thing is here. On the surface of the cells, there are protein clusters that are present and that can be identified on specific cells. For example, some immune cells, T helper cells, have CD4 on them. Cytotoxic T cells have CD8 on them. Similarly, there is another cluster of designation, CD, which is the number 147. So as scientists continue to find new clusters, they keep giving them the next numbers. So CD147 is a cluster of designation. These are set of proteins that are present abundantly on RBCs, especially on the RBCs of group A and B blood group cells, and less on O cells. And that also, so from this author's point of view, that also ties in to the reason why O blood group has less severe COVID compared to A and B. So let's continue to see this. I am B group. So of course, it is something that concerns me as well. So what happens is that CD147 present on the RBC surface is used by malarial parasite, the Plasmodium falciparum, to enter the cell. So what it does is it binds. So if you see over here, it binds with the cluster of designation and then it is internalized. Just like SARS-CoV-2 binds with ACE2 enzyme and then it is internalized. Same way over here, malaria and malarial parasite uses CD147 on RBCs. Now, It's not only just for the internalization. Malarial parasite does one more thing, and that is, if we go here, so whenever I try to make awesome illustrations, lot of them, my computer starts becoming slow and the scrolling becomes a little jerky. So my apologies. See here first. This is the Plasmodium falciparum. And these black ones are the receptor site for CD147. And these are the red blood cells. And these are CD147s, the red ones on them. And what happens is, here is the important thing to keep in mind. What happens is that the Plasmodium falciparum can actually bind with multiple RBCs and their CD147, and in that process kind of clump them together. It acts like a glue. Ideally, it does not know that I'm acting like a glue. It is just trying to get into an RBC. But while it is traveling in the blood and connecting with the RBC, because it has many CD147 receptors on it, many RBCs are going to get stuck to Plasmodium falciparum, which causes clumping of the RBCs. That is the basic core principle in today's discussion. Once the RBCs have become clumped, if you see here inside the blood vessel, those clumps of the RBCs get stuck to the blood vessel wall, because the blood vessel walls also have CD147. So it is possible that the falciparum can hook to the endothelial cell, the blood vessel wall cell on one end, and then hook an RBC on the other end and kind of clump them together. Then the RBCs can further be clumped with other RBCs naturally, or through platelets, or through more Plasmodium falciparums. So how do we, in simpler words, how do we think about this? Imagine Plasmodium falciparum is a glue, and that glue allows various red blood cells to connect and clump together, and then allows that clump to become bound to the blood vessel wall together. This would cause obstruction to the flow of the blood in various blood vessels, which in turn would cause tissue damage. Now, this phenomena of clumping would also cause white blood cells to become activated, because they will come near these clumps and they're going to say, what the heck is this? And they try to eat them up and clear them, in which process they would start the immune response as well. So this is a process in which all immune and inflammatory system can become activated. Plus, there is damage to the tissues because of the blood flow obstruction. Now, if you see here at the top of this picture, the blood group A RBC is crying and B RBC is crying. That is my RBC. And the O one is not crying. Why? Because A and B have more 147 on them compared to O. So this is how the author is hypothesizing why O group is less prone to severe compared to A and B. So far so good. We understand that RBCs have 147 on them, CD147, that can be used by something that binds with it to cause the clumping of the RBC. That in turn can cause blood flow obstructions, which can cause tissue damage. Okay, now let's continue. Now, leaving you here with the concept, before we go to ivermectin, let us see a Florida study. So I am actually going in the way the author of the paper has put the logic together. So I'm just following the same logic. So keep that in mind, that RBCs can be clumped. Now let's look at a study here. This is a ivermectin study from Florida. They used 200 microgram per kilogram body weight dose. Total people who participated were 280. 107 were in the control arm. 173 were in the treatment arm, or the arm which received the ivermectin. Here is the result. Overall, the mortality was 25.2% in placebo and 15% in ivermectin arm. So significantly lower, and the p-value is 0.03, which is also significant. Those out of the same patients, those that became severely ill, in the placebo, 80.7% died. 80.7% died in the placebo, and 38.8% died in the ivermectin. So that is how significantly ivermectin helped even in the severe cases. Okay, so keep now this in mind as well. So author would then connect the dots and say, look, here is clumping, here is the ivermectin's effect, and here is a possible mechanism. So continuing, he also talks about why ivermectin within 2 days creates its effect, number one, and number two, why its effect continues for days afterwards when the half-life is only 18 hours. He also talks about what is the safe dose that has been seen in various studies in the past. So what he's saying in his paper is that we know that when the ivermectin is given orally, within 4 to 8 hours, it reaches the peak maximum in our plasma, becomes available 4 to 8 hour majority of the dose. Then within 18 hours, the plasma concentration becomes half. So that is the half-life. But the active major metabolite, that is the main functional unit of the ivermectin, actually has a half-life of 3 days. So it continues on and it becomes half in 3 days and then further half in 3 days. This is why ivermectin can actually if taken today, can actually stay efficacious for 3 days. With this, author also says that there have been studies in the past, not for SARS-CoV-2, but for scabies, crusting scabies, where 2000 microgram per kilogram body weight, 2000, that is almost 10 times the therapeutic dose, and therapeutic dose being 200 microgram per kilogram. I use 150 microgram per kilogram, much lesser. So he said that even 2000 microgram per kilogram has not caused any safety issues. So now we talked about clumping. Then we talked about the ivermectin's effect on COVID patients in Florida hospital. Then we talked about why ivermectin can continue to stay in the body for a longer time, why a higher dose is useful. And then let's continue. We are building a story here. And then the next part is that there is a study that our author talks about, and that is Heparin Study. So now we are moving towards the coagulation issue and understanding what is happening there. Heparin Study, heparin is a blood thinner, and he's saying that there is a study that is done when people were given heparin, 1,735 patients, and the mortality in them was 45% lower than those who were not given heparin. So what is the author trying to prove here? He's trying to prove that hypercoagulability is a real problem in severe patients, and keeping hypercoagulability in control is important. Then he talks about azithromycin, and he says that azithromycin has similar effect, that it also reduces mortality. And we were still scratching our heads to say, how does it really help? And I'll show you that azithromycin, he would show, also attaches with the 147, and it also reduces the clumping or binding of the SARS-CoV-2 with RBCs. Then he talks about other studies as well, where he says that anti-malarial drugs that are, and I'll show you the drug next, anti-malarial drugs that may be targeted against CD147 have shown to be efficacious against COVID-19. So once again, he asks us to think about it, that why would something that is working with 147 will also help against COVID-19? So that all then ties down to 147. So let's see, what does that mean? So this is the This is the payoff slide of the whole discussion. So RBCs have 147. So if you see here, this blue thing in the middle is the SARS-CoV-2. SARS-CoV-2 can also bind with CD147. That is the important point to note. So SARS-CoV-2 binds with ACE2 enzyme to become internalized in the cells, but SARS-CoV-2 can actually just bind with 147, not to try to internalize, just bind with them. It has, the spike protein of SARS-CoV-2 has affinity for CD147. If that is happening, then think about it. It is the same mechanism now like Plasmodium falciparum. And that is SARS-CoV-2 is going to now clump a bunch of RBCs together with its spike proteins. And the result is the RBCs are going to be put together in clumps. Those clumps are going to settle on the blood vessel walls. That would cause the blood vessel wall damage. That would also, by starting the immune mechanisms over there, plus that would cause obstruction to the blood flow. And then author also talks about why this is not that common in youngsters compared to the older or advanced ages. Because youngsters' blood vessels are much newer, these are brand new blood vessels, and so they have better blood flows. So even if you create some clumps here and there, the blood flows are still better. That doesn't mean that youngsters do not get it. There are youngsters who develop COVID toes as well. There are children who develop it as well. But majority of them do not have the side effects of hypercoagulability because their blood vessels are much more patent and much more clean, and they have much better blood flows. Because of that, SARS-CoV-2 does not cause severe issues in them. But in the advanced age, the blood vessels are kind of collapsing. They are not that healthy. They have cholesterol getting stuck in their blood, their vessel walls, and they are narrowing. On top of that, if we add the clumps in them, then the blood flow becomes compromised much faster and the tissue damages occur much faster. So this is the most important part here. Now, continuing, what does this mean? So first, let's look at the left side here. Again, in the paper, author says that to prove this theory, they did a study in which they give meplazumab, which is a monoclonal antibody against CD147. This was actually created to prevent malaria. And why? Because what happens is we'll give the antibody that would go and get stuck to the CD147 on the red blood cell, and the Plasmodium falciparum will not be able to bind with them because these CD147 are already occupied by the antibodies, and so the malarial parasite cannot get into the RBC. It is the same thing as we say that, hey, ACE receptor binders, ARBs, can prevent ACE, the spike protein of the SARS-CoV-2 from binding to the cells. The same is the mechanism here. And they said when we use this antibody, the SARS-CoV-2 patients felt much better. So 6 severe and 7 critical patients got the virus clearance within 3 days compared to 11 control patients who were not given the antibody and they had the virus clearance up till 13 days. So isn't that interesting? That means that SARS-CoV-2 was using CD147 as well to cause more and more severe issues. Now, how does ivermectin play in this whole thing? This ivermectin man over here, we know that it binds to spike protein. Remember, we did a discussion for in silico study, a study in computer where they saw that the ivermectin has an affinity to bind with the spike proteins. So if ivermectin binds with the spike protein, then it would reduce the SARS-CoV-2's capacity to bind with the CD147 on the RBCs. It is just like if you have my hands and I use, let's say my hand is a spike protein, and I use my hand to connect with the ACE2 or CD147, and now you put some sort of a glove on my hand and you kind of tie them together, and now I cannot handle and I cannot bind to CD147. then I have become disabled. That is what we do to SARS-CoV-2 with ivermectin. That means giving ivermectin is not only important for prophylaxis or for the viral stages, it is also very, very important for the cytokine storm stages, hypercoagulable stages. And this is what I've been saying. Even in my interview this morning, I was saying this is the only drug from a mechanism point of view that is known to work from prophylaxis to viral stage to cytokine stage to long haul stage. There is no other drug that has been seen to be effective in all those stages. For example, prophylaxis, no drug. Outpatient, maybe symptomatic treatment, maybe bamlanivimab or plasma or other monoclonal antibodies. Then again, you know that outpatient patients have actually no treatment. Then in the severe cases, steroids or remdesivir in the viral stage in the hospitals. And after the severe stages and after the stage where the long hauling may occur, there is nothing. And if you put ivermectin in at all of those stages, it works. So including the hypercoagulable stage, and this is the possible mechanism. Continuing, then what is their what is their takeaway? What is their conclusion? What they're saying is that please make sure that you're not just giving ivermectin at low dose like Dr. Mobeen does. They didn't put my name in there though. 150 microgram per kilogram body weight. Don't do that just. They said start with 500 microgram per kilogram body weight stat. And then every 3 days, because the half-life of the active metabolite is 3 days, 250 microgram per kilogram every 3 days. I would probably add that this should be targeted more towards hospitalized or patients who are dropping their oxygen levels. In the prophylactic stages or in the outpatient stages, lower dose should be fine. But this is what author is saying. So I don't want to editorialize them. I want to understand what they are saying. So this is what they're saying. Now, having said that, let's look at very quickly, just review what they are, how they have structured their paper. So here, so this is actually one author, David Scheim. So here they start with the Florida study, and then they talk about the results in the study. Then they talk about CD147, the role of CD147 in the RBCs. They talk about A group, B group, and O group. Then they talk about azithromycin and how azithromycin has shown efficacy against COVID-19 while it is really an antibacterial. So why is that? Because azithromycin also actually binds with CD147, preventing SARS-CoV-2 from binding there. And then they talk about hydroxychloroquine, interestingly, antimalarial there as well. Then they talk about other studies with the ivermectin that I have just shown you. Then they talk about how high dose. Then they talk about CD147 and red blood cells and their clumping together. They have a diagram which is beautiful over here. This diagram, so if imagine that this is a platelet, this is a SARS-CoV-2. My diagrams have SARS-CoV-2 as big as the RBC. These are not anatomically correct or to scale. But here is the SARS-CoV-2, here is an RBC, here is an activated platelet. So the clumping has started and then the clotting has started as well. So then these platelets and RBCs can get stuck on the blood vessel wall as well. And this is one more diagram in which they are showing this. One more such diagrams. And finally, with this, they say that, hey, white blood cells can start working as well. Then they connect the dots for various signs and symptoms of COVID to this hypothesis. And they say, look, increased incidence of COVID-19 with increased age is because of the blood vessel integrity that is reduced. Then various blood groups, and the difference is also because of CD147. Then quick decrease in hemoglobin levels, or sorry, oxygen level, is because RBCs are affected by COVID-19, and so on. So they just continue to go over these. And finally, they talk I didn't have time to go over this all, but what they have done is finally they have talked about the distribution of ivermectin in the body plus the high doses of ivermectin and their safety. So this is the discussion for today. I hope it kind of makes sense. The takeaway, I'm going to just summarize it once more. The takeaway is use ivermectin, use at a higher dose, and must use in COVID because it has an effect by blocking the virus from attaching with CD147. So if you like, I'll hang up now and come in for chit chat. If you want to take off from chit chat, then we can be off. Laura says Dr. Bean's drawings are so much better than it scrolled, it went. So do you want to do a chit chat? Patricia Hawk, so are you saying that SARS-CoV-2 acts extracellularly as well as intracellularly? Yeah, so Patricia, on one end, it binds to ACE2, goes into the cell, makes more viruses, destroys the cell, causes inflammation, immune system responses, tissue destruction, and so on. On the other end, according to this paper, it can bind with 147, does not go in the cell. It is not an entry vehicle. It is just a binding vehicle. It loves to just bind with 147. And in that process, imagine it has 1,000 spikes on it or 200 spikes on it. And they all bind with one RBC. Now, one SARS-CoV-2 has 200 RBCs clumped with it. And that causes the hypercoagulable state and further damage. So that is, yes, in your terms, that is the extracellular behavior. So Giladoni says, where can we get the copy of the paper? So I showed that right in the beginning. So if you go here, and I have these links in the description. So if you go here, this is the paper in SSRN. And then if you can download it, you can see the paper in PDF form as well. And this is not a new paper. It was written in June 26 and posted on July 2020. So it has been out there for some time. It's just that Julian showed it to me today. So my bad that I was late on it. Okay, France says chit chat. Oui. Okay, I am gonna hang up and come back. So here is my request to you. Please like, subscribe, and share. And there are links in the description if you wanted to buy me coffees. Coffees are welcome. Or if you wanted to become a patron, that would be awesome. And then if you wanted to just support this channel and our work as well, that would be great as well. So thank you very much. And I'll see you in a short second.